everyone. Today I'm going to present to you a lecture on antibiograms and their importance and benefits. My name is Dr. Sara A. Eltigani. I'm consultant medical microbiology in Jazan General Hospital. I have been working as a microbiologist for almost more than 12 years, and I will be very happy to present to you this important topic. Maybe recently you have heard the term antibiogram, and to the people generally this term means antibiotic susceptibility. But today, inshallah, we are going to understand it from a different point of view. So why do we need antibiograms? Hospitals usually use antibiograms as part of infection prevention and control measures. In what terms? In the term of classifying the type of bacteria for different patients in the hospital, and also identifying the different patterns of antibiotic susceptibility. And not only that, just also tracking the changes in the antibiotic susceptibility, the increase or decrease of susceptibility or the improvement. Also, hospitals use different types of antibiograms. There is what is called cumulative antimicrobial susceptibility, and this is usually defined as putting the bacterial agents together and seeing their initial susceptibility patterns. And also the agents that are used as antibacterial agents are usually initially the antimicrobials that are used in empirical therapy, so that they are to target or to select empirical antimicrobials so as to help in reducing the inappropriate of antibiotics use. So in brief, in one side it's classifying bacteria and patterns and the susceptibility and the changes, and on the other side the use of cumulative antimicrobial susceptibility to help in selecting agents for initial empirical antimicrobial therapy. So what is the antibiogram? We have cumulative antimicrobial susceptibility test data report. So what do we mean by cumulative? It means that we have on a specific certain time, for example 1 year, so we have a lot of information, a lot of data that is present there in terms of bacteria and the susceptibility pattern. So either we use this information in terms of routine antibiograms, and the aim of a routine antibiogram is to guide the clinicians in selecting empirical therapy. So you will have a list of the antibiotics, and you have the list of bacteria, and each bacteria has different patterns of susceptibility pattern to different kinds of antibiotics that are usually used to this bacteria. So you define that, for example, Pseudomonas aeruginosa is susceptible to ceftazidime by 90%. So it is very good to use ceftazidime as an anti-pseudomonal drug. This is the usual antibiogram primary aim. So what are the other types of reports that we can generate from this kind of data? We can identify the emergence of resistance or rare phenotypes, because in antibiograms reports we do not identify the resistance patterns. We give the percentage of susceptibility, and we are going to see this in the coming few slides. So if we can generate or we can show from the data available that there is an emergent resistance or rare phenotypes, this is outside the routine antibiograms used. Also, we can do by assessing the susceptibility profiles among all isolates in database. It means that we see all the isolates and we see the different susceptibility patterns. So it means that we are not only targeting certain kinds of bacteria or certain kind of or one bacteria for multiple antibiotics. We are targeting all the isolates and all the antimicrobials that are there, or antibacterials. Also, we can find, and which is outside the scope of a routine antibiogram, trending antimicrobial resistance. For example, that the development of ceftazidime resistance in Pseudomonas aeruginosa strains that are present, for example, in this hospital. If the resistance is very high recently, so it means that there is a trending in antimicrobial resistance, and this is very important for public health, because actually the patients harboring this Pseudomonas, or for example E. coli, the patients harboring E. coli, which is an ESBL, for example, are coming from the community. So it is very important for the public health to know this trending in antimicrobial resistance. So now from this slide, what I want you to remember is that the cumulative antimicrobial susceptibility report can give you either a routine antibiogram or out of the routine information. Now, what are the requirements to develop the antibiogram? We need results of cultures, including the concerning antibiotic susceptibility. So we have to select the types of antibiotics we are using. We need a laboratory, it could be from the laboratory, either in a form of electronic or paper-based. We have here an electronic form, or a mixture actually between the electronic and paper-based. Also, the culture ID, the patient ID, the name, the culture date, the source of the culture, and the results, the organisms, of course, and the antibiotic susceptibility. This is an example of an antibiogram. Let me explain it to you. These are examples for the gram-negative organisms, and these are examples for gram-positive organisms. So how can we read this table actually? If you have E. coli, for example, 4 patients had E. coli. All of these patients, they had 100% susceptibility to amikacin. It means that all of four of the patients were susceptible to amikacin, not intermediately sensitive and not resistant. All of them were susceptible. The E. coli that were isolated from the 4 patients also were susceptible to gentamicin, tobramycin. And for ampicillin is not applicable, because usually we do not challenge gram-negatives with the ampicillin and penicillin, for example. Also for imipenem, it was 100%, until you reach ciprofloxacin is 75%. So if you have 4 isolates and 75% susceptible to ciprofloxacin, it means that 3 out of 4 were susceptible to ciprofloxacin. This is the way that we can read it. You can see here that Klebsiella species were around 30. So there are different patterns of sensitivity, sensitive percentage. It's a percentage. For example, trimethoprim sulfamethoxazole was 38.5% only susceptible to in Klebsiella. So maybe it's around one isolate only that was susceptible, and the rest were resistant. Now in Proteus we have 7. Also, like gentamicin, almost 50% were susceptible. It means that maybe it's 3 patients or 3 patients with 3 types of species of Proteus. They were only sensitive, and the rest were 3 or 4, and the rest were resistant. So this is the way that we read the antibiogram. Let us go to the gram-positives. For all Staph aureus, they had 8 patients, and all the 8 patients were methicillin resistant, and 0 patients were methicillin sensitive. So the methicillin resistant, they were definitely resistant to penicillins and oxycillins because they had the MecAG. But gentamicin, there was 87%. And of course, for the types of antibiotics that are usually used in the case of MRSA, all of them were 100%. And if you are having a urinary isolate, you will use nitrofurantoin for that one. So for enterococci, like Enterococcus faecalis and faecium, they had 100% sensitive. The 4 of them were 100% sensitive to penicillin. But of course, we don't give in enterococci only penicillins. We give them in combination with gentamicin. So we have to combine it with another antibiotic. 75% were sensitive with gentamicin. So the combination between gentamicin and penicillins or ampicillins worked only in 3 cases, because 75% out of 4 means 3. So we had 1 that were not with the synergistic effect between penicillin and gentamicin was not working, and the rest of them, the 3 of them, they had synergistic effect between ampicillin or penicillin and gentamicin. This is the way we read actually an antibiogram. So there are certain facts for antibiograms. It is an essential resource to track changes in antimicrobial resistance and to guide empirical therapy. It is a useful tool to utilize the specimen to estimate the prevalence of antibiotic susceptibility, and also they are essential component in monitoring trends in antimicrobial resistance. Considerations in developing and reporting an antibiogram. A cumulative antibiogram is actually a periodic profile, so that you have to define a certain period of time of antimicrobial susceptibility. You have to have an antimicrobial susceptibility patterns in the facility, and you have to have an ID for the organism. So if you don't have an ID of the organism, the antibiogram cannot be done, or the isolates that are not identified, they cannot be part of the antibiogram data. So there are conditions for a cumulative antibiogram: a specific period of time, presence of antimicrobial susceptibility, and presence of identification of the organism. Also, it can be developed to track the resistance of patterns in a broader geographic areas. For example, we can have multiple institutions having studied their antibiogram. So these could be the types. So we have like 8 key recommendations that should be followed when construction of a routine cumulative antibiogram. If you can follow me here. The first condition is that, or recommendation is that, you need to analyze and present cumulative antibiogram report at least annually. So you need to have an antibiogram in place at least once a year. And you consider multiple analysis within rolling 12-month period of time, and only when critical trends in resistance are detected we require time education of prescribers. So it means that the timeline requires a 12-month period of time, so that you can monitor critical changes in trends in resistance. The recommendation number 2, only diagnostic, not surveillance isolates. So if there is a surveillance ongoing, it shouldn't be part of the antibiogram. Also, if we have only final verified test results, so not the results that are preliminary should be incorporated. Also, we need to eliminate the duplicates. For example, if a patient one species from a patient was isolated multiple times, we need to count that as only one. And also we need, regardless of the specimen source, for example, different kinds of specimens providing us with a single organism on different times for the same patient, we need to only consider this as one isolate and one patient. Only we include the species that are testing data but that are more than 30 isolates. We also include only antimicrobial agents that are usually used. We never include antimicrobial agents that are rarely used or not used unless there is a certain condition. It will be in the form of a percentage, and it will be calculated from the reported results. Also, we need to refrain from these results supplemental antimicrobial agents, selected only if there is resistance change. So the second line and the second or third line antibiotics should not be used. And also we need to have reports in the form of percentage as we mentioned. We do not incorporate intermediately sensitive and of course the resistant. Additional recommendations is that, for example, in the case of Streptococcus pneumoniae, we have cefotaxime, ceftriaxone, and cefepime. The list of sensitive using both meningitis and non-meningitis breakpoints for penicillin, and also indicate that the percentage using oral breakpoints. Also, we incorporate the oral breakpoints also. For Staph aureus, we list the percentage of sensitive for all methicillin-resistant Staph aureus subset. And if a specific agent are tested on isolates from specimen, for example, urine specimen, when we are preparing the antibiogram, urine isolates should be considered. So you need to consider all the types of samples. These are the 8 key recommendations in constructing a cumulative or routine cumulative antibiogram. So what should you know before you decide to use an antibiogram information? Antibiograms are not generalizable. So if you have like in a specific setting, you cannot generalize that one for all the other facilities. And they are a valuable tool in guiding empiric therapy and monitoring antibiotic susceptibility trends in a specific health setting. Also, in the empiric selection in a particular healthcare setting, we should not be based only on the antibiogram. The patient infection history, including past antimicrobial use, also must be considered. We have also antibiograms will capture aggregate of proportion of percentage for a given organism on time. They do not provide prevalence, and if you are as a prescribing clinician, you need to also examine and identify the 1 or 2 antibiotics that are not working. So these are the benefits. From the antibiogram, you need to understand if there is a certain antibiotic that is not working, how exactly it will be recommended. For example, the name of the antibiotic is not working for urinary tract infections because significant resistance developed, and please avoid this antibiotic. These are the recommendations that could be provided from the antibiogram. What should you know before you decide also to use an antibiogram? Antibiograms provide binary measures of susceptibility, whether an organism is susceptible or not susceptible, but do not provide quantitative data, such as MIC, minimum inhibitory concentration. You are not going to be expecting from an antibiogram that it will give you the MIC, or even further categorize the non-susceptible into intermediately sensitive or resistant. So what you have, you're going to have the percentage of the susceptible only, without the MIC. Also, granular data such as MIC distributions below the clinical breakpoints are not reported on the antibiogram. So also will not find the MIC that are below the clinical breakpoint. For optimal antibiogram utilization, it is less precise when the infective organism is not known. So if the organism is not known, it will not give you a good antibiogram. So it is very important that you have the organisms identified for the patients. Also, based on the site and or the type of infection. It should be practical and user-friendly. So, for example, abbreviated antibiogram will be easier to read, and at the same time, the abbreviation will be standardized and well known among all physicians. Susceptibility data from an antibiogram should be utilized when generating infectious disease treatment pathways. So you need to go back to the antibiogram and see it when you want to generalize or adopt any kind of infectious disease treatment pathway. This could be in the form of computational models. For example, if you would like to have it an easy way, it can be in a form of a computational model or artificial intelligence to predict antimicrobial susceptibility. Also, the predictive models are available to forecast bacterial resistance and therapy selection based on various factors such as risk factors. For example, the site of the infection, the community or the hospital acquisition, the microbiology data, diagnosis, and antimicrobial consumption. Also, antimicrobial resistant models do not take into consideration the social and cultural behavior differences associated with resistance, development, or transmission, and the dissemination of antibiogram to the frontline prescribers in an institution where clinical pathways or order sets are not utilized may prove to be challenging. Studies noted that feasibility disseminated a pocket antibiogram through electronic means such as a mobile application device or something like that. So it will be more handy and useful and easily to be read for frontliners. So in implementing antimicrobial recommendations based on the antibiogram, when we develop an empiric antibiotic list based on common pathogens and susceptibility reports, alternative agents for patients, and antibiotic allergies or organ dysfunction also should be included in the antibiogram. Institutional antibiogram prescribing policies and disease state algorithms accounting for allergies and organ function can be added to the back of the antibiogram page at the end of it, and also facilitate related projects, antibiogram related projects, such as studying specific resistance pattern and relating it to the patient's outcome. So antimicrobial causes delays in instituting pathogen directed therapy, while challenging to study risk factors analysis can improve early empirical therapy in specific patients or populations, and also in with high mortality rates, such for example in hematology, oncology, transplant, and ventilator associated pneumonia. So all of these clinical situations, challenging clinical situations, the antibiogram can help a lot in directing the therapy when we are relying on the specific data that is provided by the antibiogram. Who monitors antibiotics generally? It's the Antibiotic Stewardship Committee and the Infection Prevention and Control departments. So for antimicrobial stewardship programs, antibiotics have extended the life expectancy in the world since antibiotics were discovered, and they reduced the morbidity and mortality rate from dangerous infections. On the other hand, the overuse of antibiotics, the evolution of resistance, which would result in hard to treat and often untreatable infections, which are now considered worldwide challenging. Antibiotic stewardship programs are intended to improve patients' outcomes, reduce side effects, reduce bacterial resistance, and reduce cost. So it is essential to assess the antimicrobial stewardship program impact on ongoing basis. The need for antimicrobial stewardship committee is that antibiotics resistance leads to ineffective therapy and forcing the health providers to use more toxic agents for longer durations and increasing the overall cost because the patient will stay longer and utilize more expensive drugs. The overuse of beta-lactam antibiotics expanded the occurrence of carbapenem-resistant pathogens, so that the Center of Disease Control estimated that around 30% of antibiotics used in hospitals are inappropriately or unnecessary. For example, in Jordan, the prevalence of self-medication is significantly high. Another study showed that 50% of physicians prescribe antibiotics for inappropriate indications such as common cold. 67% of adults, Jordanian adults, believe antibiotics should be used, and 28.1% misuse antibiotics as analgesics. 49% also there were leftover antibiotics without physician's consultation. They took them over the counter. What is the effect of antimicrobial stewardship program on bacterial resistance? It actually changes the antibiotic susceptibility to become better. It defines the defined daily dose per 1,000 patients, and it decreases the development of ESBL, VRE, and MRSA infections. What is the effect of infection prevention and control on bacterial resistance? They actually implement and elevate the baseline of precaution, which is coinciding with the type of resistance. And the control measures are also directed at the carriers of the infected or resistant organism. Also, there is prioritizing the protection of vulnerable hospitalized patients, and also the resistance is found also in humans, animals, and in the environment, including the soil and wastewater. These resolvers contribute to the epidemiology of resistant underuse, overuse, and misuse of antibiotics. They also, the infection prevention and control, they screen almost exclusively targeted people who need to be hospitalized and are thought to be at high risk of colonization. And also they are implementing solidary isolation approach of acceptable risk cohort, either to put them together or to keep them separated, and a lot more. So infection prevention and control, they prevent the healthcare associated infections, and these are usually through hand hygiene, personal protective equipment, standard precautions, environmental cleaning, decontamination of equipment, transmission based on precautions. They have bundles of infection interventions, and they monitor and evaluate the prevention interventions and hospital-acquired infections. For antimicrobial stewardship committee or program, they structure and governs and oversights antibiotic use. They at the facility level interventions also they monitor, and at the patient level, does the patient need an antibiotic or not, which antimicrobial, and now they have an antimicrobial what next. Also, they monitor and evaluate antimicrobial sensitivity interventions. The most important component in all of these for the infection prevention and control antimicrobial stewardship is that there should be training which will change the service and the service and behavior change as well. I'm very thankful for you all to attend this lecture. I hope that you have uh, benefited from it, and I did it in a concise way. I hope I didn't go through the details so much. So I hope that you read the antibiogram of last year with another point of view, and I'm open for all questions on the link that you will find. I will try to upload it in the YouTube, and I would be happy also if you can ask me directly. There's no problem also. Thank you very much. Sara A. Eltigani. I hope to meet you again in another lecture. Salam alaikum.